So our first talk tonight, concentrating on ultrasound, is by Dr. Thomas Grant, Professor of Radiology at the Feinberg School of Medicine at Northwestern University here in Chicago. His illustrious career of over 20 years includes multiple appointments at University of Chicago, University of Illinois at Chicago, and most recently, Northwestern University Hospital. In addition to being awarded Fellow of the American College of Radiology in 2004, and the Society of Radiologists in Ultrasound in 2010, he's received Distinguished Service Award from the Chicago Radiological Society. He has served in numerous scientific and professional societies, holding many different roles, including President of the Chicago Radiological Society, and is, of course, well published in the field. While his career and specialty have certainly focused on body imaging, I look forward to hearing more about why his talk is not going to focus on liver imaging, but instead high-resolution MSK imaging using the new Toshiba Medical i800 ultrasound. Please welcome Dr. Tom Grant.
Yeah. Good evening, everybody. I want to thank Toshiba Medical for inviting me and letting me talk on my favorite subject, musculoskeletal ultrasound. Why I use ultrasound for MSK disorders? One is there's no contraindication. There's great patient interaction. The resolution of ultrasound is really quite a bit superior to MRI, especially when you're talking about nerves and tendons and muscle disorders. There's much better contrast resolution as well. I've been really pleased to have used the I-Series for the month of October, looking at a bunch of different musculoskeletal disorders, using it, and this transducer has really been a boon to me as far as imaging. This is an example of a terminal tendon of the index finger, of the ring finger. Now, this is a representation right here, and you can see there's actually the ability on this. This structure right here is a terminal tendon. This is 1 millimeter, and yet you can see individual fibers of that tendon, which is I've never been able to see before. This happens to be normal, but I think the resolution is quite spectacular. This was a conventional ultrasound we did, and the patient was having shoulder pain, likely due to rotator cuff. And at the junction of the infraspinatus and supraspinatus, we see this hypoechoic area. And we weren't sure if it was tendinosis, a partial tear, or complete tear. We brought the machine in, the Toshiba I-Series, and we can see that in this representation, you can see there is actually a complete tear of this, and we had no difficulty calling the tear, as opposed to using conventional imaging, unable to make that diagnosis. We're also be able to see really normal anatomy. This is the anterior talofibular ligament between the fibula and the talus. You can see the individual fibers. This ligament is very frequently injured, injury to the lateral ankle. We can see the supraspinatus tendon right here attached to the greater tuberosity and foot plate. Really good imaging of the ulnar nerve. This patient happened to have ulnar neuropathy, and there was a big fibrous band compressing the ulnar nerve in the cubital tunnel. This is a Dupuytren's lesion or contracture, and these are not uncommon in Northern Europe, but they are also seen in diabetics and alcoholics, and usually it involves the fourth and fifth fingers, where in the extreme form you get a flexure contracture, and there's a fibroproliferative cord of tissue that develops. And these are very difficult to treat, and I think the reason they are difficult to treat, because if you look here, instead of being a superficial location, it's actually infiltrating the tendon sheath, making it really difficult to treat. And here on the transverse image, we can see some compression on the lumbrical muscle as well. I'm sorry, right here. A patient who, IV drug abuser, who came in with the sternoclavicular joint pain. We were seeing kind of a heterogeneous focus in the sternoclavicular joint, but on the video clip, you can see some of this is liquefied material. We very quickly then put a needle in, got pus, and were able to quickly culture that material and send it to the lab. This is a 17-year-old girl. This is from only a few weeks ago. And she had internal fixation, open reduction internal fixation for a fracture of the ulna. And what was interesting is that she was already having ulnar neuropathy, and she was actually losing muscle mass in the region of the hypothenar muscle. And I'll show you what we saw. We saw the plate right here. We can see the bone surface, the ulnar bone surface, the plate. We can see the ulnar nerve entering the plate and exiting the plate, but the nerve was between the plate and the bone. This is a diagnosis that's readily made with ultrasound, but what was impressive was how quick we were able to make this diagnosis, and I think it was very helpful to the patient because the plate was removed the following day. Another patient with a peroneus brevis rupture. This is an unusual injury. Usually they're split tears and not complete ruptures. This patient's been having lateral ankle pain for over a year. No diagnosis had been made except for that the tendon was actually attacked. So you can see the peroneus longus and brevis tendons right here. And then you start to lose the brevis adjacent to the lateral malleolus. And this is what the representation of it looks like here. But you can actually see the normal tendon fibers stop right here, and this is all synovial thickening in tissue. So this is a complete rupture of this peroneus brevis tendon. A patient who had a primary repair of her flexor tendon, and during a very aggressive therapy session, re-ruptured the tendon, and the orthopedic surgeon, the hand surgeon, wanted to know how close are the two ends. So we can see the distal end of the tendon right here, adjacent to the distal end of the proximal phalanx, and the more proximal end was suture material here. So we knew exactly the length that was needed for him to repair this, and actually this required a tendon transfer. Another patient who had a knife stabbing injury to the median nerve. These are swollen fascicles of the median nerve in the distal forearm. We can then see the scar tissue traversing the median nerve, where you can see very readily that this portion of the nerve, the outer surface or sheath, was disrupted, meaning that this required a nerve graft as opposed to a primary closure, which was very helpful for the surgeon to know. Another patient who actually fell on their forearm, the patient actually was on Coumadin. We didn't know if this was a neoplastic mass or a hematoma, but the SMI readily shows that there is no flow within this at all. And we can see the tendon right here, and we can see this mass, which turned out to be a hematoma and not a muscle mass, because this resolved within 2 weeks. Another patient, this is known as a turf toe, which is an injury to the fibrous cartilaginous capsule tissue between on all the metatarsal phalangeal joints. And you can see this was a football injury, but this lady was 60 years old and fell off a ladder and was having severe pain on the plantar aspect of her first toe. And we can see a normal plantar plate on the opposite foot and a complete rupture of the plantar plate on the affected side. Finally, this was a young woman in college who had shattered glass go through her tendon. The tendon was repaired, but we only realized later that look at the distance between the tendon and the bone. So she was, despite the fact that the tendon was repaired, she had no functional ability. And the reason for that is because this was a pulley injury that held the tendon down. And we can readily see the normal tendon, but these ruptured tendon, as we see here, ruptured pulleys, prevented this from healing. And finally, one last case of a vascular tumor, which we think is going to be a glomus tumor. But the reason I'm showing this is because this is a digital nerve, very tiny nerve, and yet with a 24 megahertz transducer, you're actually able to make out multiple small nerve fascicles. And the SMI showing that there is internal flow within this lesion. So anyway, I've had a chance to use this for the month of October. I've been really impressed. This 24 megahertz transducer has made it a lot easier for us to differentiate normal and pathologic conditions. And to be very honest, I haven't seen anything this good. Thank you very much.